Okay, so now top 10 trials of coronary intervention 2024. We give June, and then now this will be 50% different. With what I showed in June, and all the references now will be of 2024. You'll have no reference of 2023. I always start my lecture with this, the tribute for coronary intervention to Andreas Grundzig, for which, because of him, we are here. As a father of angioplasty, as a dream was catheter-based percutaneous treatment of vascular disease in alert and awake patient. And with utmost, that's my addition to this, utmost safety, appropriateness, and ambulatory means it has to be needed. Not that because there is a lesion, that it has to be appropriate to do it. And many of these cases are done as an outpatient. So this is what we are going to do. Some trials which are kind of changing our practice of 2024. So it started with the mechanical circulatory support in cardiogenic shock. So ECLS and 2 trials there. These are the devices which we use for shock patient. Balloon pump, which is the oldest. Impala in the middle. There is another one used to be PTVA, which is a little complex, kind of more with very selected group. And then the cardio help, which is ECMO. Remember the ECMO used to think, oh, surgeon said to do it. No, it's a percutaneous. We do it in our cath lab. In high, and I made that high busy cath labs all should have ECMO, because any cath lab catastrophe, you can take care of it, stabilize the patient till ultimately surgical or some other intervention is done. So much so, I have my hospital in India, we have 2 ECMO machines. So any good hospital should have ECMO in the cath lab, because that's a life-saving. Now, 2 trials, 1 negative, 1 positive. One was the ECLS ECMO in the shock from Germany and Slovenia. They presented a 30-day data, and now the 1 year, that is whether ECMO helps patient compared to your routine treatment. And basically, answer is at 1 year, you can see identical, no difference between ECMO versus the control group. And this is like 30-day, and this is 1 year. Absolutely no difference. While you say that this is a device should improve life, but no. So, well, okay, maybe not the mortality. What about other points? The neurological, myocardial infarction, repeat revascularization, and answer to that is none. So, okay, it didn't help there. What about maybe those patients with the ECMO got a little more like quality of life measures, as you can see here, and that too also negative. So it turns out to be all the way negative of the ECMO in the cardiogenic shock patients, the way the trials done, which is the 2 trials were last year, which were negative for ECMO. But we had a 1 positive trial. And this is the trial, which is the danger shock. It started with Germany, Denmark, and then they needed a German because the trial was very tough to recruit. Took 10 years to complete. And the trial was the Impala, which we call it, like generic name is microaxial flow pump, compared to standard of care. Again, cardiogenic shock patient, and basically showed the difference. It was 180 days, 6 months data, that within few days, within 1 month, you start seeing the curve separation in favor of Impala compared to standard therapy, about 13% decrease in mortality, and this was a tremendous. It did come at cost of some. That is what? Their cost basically was higher bleeding, higher limb ischemia, higher sepsis. Why? The catheter is 14.5, 15 French. Now we are working on to bring catheter 9 French. By next year, there will be 2 companies will be approved, and I'm PI of one of them, the 9 French catheter. So that will decrease many of these complications, and the absolute decrease of mortality of 13% may even become bigger. But also, therefore, very positive, and we keep using Impala more and more for patients with a cardiogenic shock. People used to believe that this may decrease the renal dysfunction, but did not happen in this trial. So this is also the trend showing the ECMO, balloon pump, and Impala. Overall, the balloon pump was balloon pump, but there is quite a big growth in the country. As you can see, this is basically a big Medicare database. Impala used quite a bit. ECMO, only problem is ECMO has yet to show any difference in outcome. Being used, but maybe we're using it too late. So that's the only question, that ECMO is used, numbers are increasing, but no clear-cut benefit of the device. Second, The procedural versus spontaneous MI that we always talk about. Then you do procedure, you have MI, you follow the patient have MI later on. That is the spontaneous, the differential mortality. This is a paper came out from our interventional database of Mount Sinai. The patients were followed. As you see, large number of patients, 11,000 patients. Those who had the chronic coronary syndrome, patient with acute MIs and so were excluded. And then we have patients who had after PCI, no MI, and some have procedural MI, 10% have procedural MI, and 89% are no MI, and then followed with patients who were spontaneous MI. So up to 1 year follow-up. So overall, correlated the troponin release. Less than 1 time troponin, 1 to 5, 5 to 35, more than 35. You clearly, more than 35 means really you created a bad PCI. And that happens in less than 1% of cases. So it does happen. It's similar to our CKMB of more than 10 times, which is what we used to do before. But then what basically, of course, these patients are different. Those who have procedural MI, they're more complex disease, multivessel, diabetic, more risk factor. But what a very important observation came, that procedural MI, there is a big difference in, of course, no MI is in the blue, 1.4 mortality. If you have a procedural MI, mortality is 2.2. There's no difference, p-value, no difference. But if you have spontaneous MI, it is almost 3 times, 6.4%. So remember many of the interventional trials, they have higher procedural MI, but they're lower spontaneous MI, and the medical therapy group, like ischemia, higher spontaneous MI. So therefore, you follow those patients long term. The spontaneous MI will give you more trouble compared to the procedural MI. So why? If you take the individual, the 1 to 5, 5 to 35, as you can see here, the spontaneous MI is still showing the difference in terms of HR. But only when it is more than 35 times, the procedural MI comes in the equation. So basically means that the little troponin release after PCI, not bad. It is the spontaneous MI which really create the trouble of any level. So key is that not only doing the PCI, now you have to take care of the rest of the vascular bed with all the great things which we learned today in terms of secondary prevention. And this basically the paper was the central figure. And so therefore, conclusion was, mortality at 1 year was significantly increased after procedural MI and spontaneous MI when troponin was more than 35 times, but less than that was only for spontaneous MI. So you say, why? Why two things should be different? So I actually have some explanation. That is, because procedural MI happens in the hospital monitoring. We all know some percent of MI present as arrhythmia. It's nothing to do with how extent the infarction is. So you happen in the hospital, patients will be saved. Then procedural MI may be reflection of the diffuse atherosclerosis rather than true myocardial injury. And same thing is many of the procedural MI is because of demand, patient tachycardic, hypertensive, and so. So most important, in my opinion, is the number one, and that's the reason. So at least actually there is a lot of emphasis going on in these trials of interventional versus non-interventional therapy, whether surgical or PCI, that procedural MI should not be counted, because this is just the part of doing the procedure, and it does not have a bad outcome. Then the latest data on the drug-coated balloon. Basically, what is the drug-coated balloon is, the drug is on this, the balloon, balloon is inflated, and the drug goes into the vessel wall, and it can be used for patients who have in-stent restenosis that already have DES, develop ISR. And then second is in the de novo, that you don't use the stent. Go away from the stent and just use the drug-coated balloon. The reason, all the drugs which we use for the DES all have been tried, and the favor that why the drug-coated balloon could be better, because short depth, you're not putting a stent. Then there is no chance of stent thrombosis. And also there is no additional metal, less inflammation, less side branch closure. So all those are theoretical benefit of the drug-coated balloon. So there were 2 trials, I would say, that actually one just recently presented is about the side branch, but I'm going to talk about 2 of them. One was for the ISR. This is the Boston Scientific agent drug-coated balloon compared to balloon angioplasty, 2-to-1 randomization, and showed that by using the drug-coated balloon, the TLR, need for another procedure, or MI rate all decreases with the agent drug-coated balloon compared to your conventional balloon angioplasty. Yes, but the point is, what the trial did, they randomized the patients against balloon angioplasty. The guidelines are that when you have a DES restenosis, your first treatment is another DES. But that was not part of the trial. It was only the drug-coated balloon against the balloon angioplasty. But it was positive. That led to the approval by the FDA. Individual points here, and you saw it. There's no stent thrombosis. Then there was a second trial from China, very important, present in European society. That is rack cage-free. Compare drug-coated balloon strategy compared to DES in the native vessel. All comers. So clearly, this is a different trial, the different paclitaxel-coated balloon with SWIDE, and Firebird was their sirolimus-eluting DES, took the non-complex lesion. Don't take very complex, but non-complex lesion. Why? Because they want to see that can drug-coated balloon alone work. You take very complex case, you know you are going to put a stent. But non-complex lesion, compare the drug-coated balloon against the drug-eluting stent, and basically what they found, as you see, individual endpoint of the primary, which we call DOCA, device-oriented composite endpoint, cardiovascular death, TLR, and myocardial infarction, all in favor of the DES. So DES was better, as you see in every aspect. So DES is the red, blue is DCB. So while the agent trial was in favor of drug-coated balloon, all of a sudden now, in the native vessel, you see it other way around. And actually, even mortality just made a p-value. And of course, yes, thrombosis rate was not different, and the bleeding was slightly higher in the DES group because you give longer antiplatelet therapy. So clearly, it seems to be that in a routine native vessel, drug-coated balloon was inferior to the drug-eluting stent. Now, second point is that was there a difference in terms of the vessel size? Yes. In a small vessel, there was no difference. You can see left side, 5.1 versus 4.4. But if you have the non-small vessel, large vessel, the drug-coated balloon had a 3 times higher event rate, 7.5 versus 2.5. So clearly, not in large, what we have been doing, continue doing the drug-eluting stent, and a small vessel, if some situation you want to decide doing the drug-coated balloon will be all right. So their conclusion was that DES should remain the preferred treatment for the patient population. And so next one is the imaging trial. There are a lot of imaging trials which I presented last time, and now there are a few of them. Basically, that imaging adds to our angiographic interpretation. So we want to come up with the best results. We have been doing good angiogram and good results, but can you improve it further? And recent all data have shown that once you use imaging, take some time, maybe a little cost, but you improve the outcomes. So all trials have consistently shown imaging, and then these are the physiological, which is FFR and IFR, all are incorporated in our daily armamentarium. We use them routinely to make the decision. So of the latest one is the OCUPI trial, basically the trial from South Korea, OCT versus routine treatment in the complex cases. Complex was MI, CTO, bifurcation. So randomize them to the OCT versus angiographic guidance with a 1-year outcome. And basically, they have very good criteria of the OCT, that your stent has been fully expanded, no dissection. So very, I would say, intricate and the detailed analysis. And basically what it did, it showed significant reduction in all the endpoints with the OCT guidance versus angio guidance. You can see your MACE, your TVR, and no other difference in stent thrombosis. So basically what we learned, the OCT in complex lesion did better than just angiographic guidance. And now another point we found, that this is here, 7% in the angiographic, and with the OCT guidance was 5. But if you have good OCT, optimal OCT, which we call, they call basically the suboptimal OCT and optimal OCT, event rate was within this 5%, became 9 versus 3. So now you are saying that your good stent optimization, the OCT 7% versus 3%, significant improvement in outcomes, so decrease with the OCT and so. So therefore, the conclusion was that indicate the existence of a therapeutic benefit of OCT as an intravascular imaging technique for PCI guidance in patients with a complex lesion. There was another trial, which is basically the second trial of the ultimate three, where they did the imaging before the drug-coated balloon. So basically also showed that once you use imaging to get a drug-coated balloon procedure, the overall event rate was lower, although p-value was not significant, but lower in favor of the IVUS versus the angiography. Then we say, well, you are doing the imaging, now we're actually going to just angiogram QCA. So you're not putting any new device, just by QCA. And this is basically the data of the GUIDE DES trial, where the QCA guided showed similar data as the IVUS guided. So things are improving in this imaging field, and so on and so forth. So what Greg Stone, who is with us, put all these things together with multiple the trials in the meta-analysis using the NGO, OCT, IVUS, and the message is in this slide, that by using if you combine all the trials, many of the trials are not part of it, which I showed today, but this is up until earlier this year, that if you use imaging and just concentrate on this side, that you decrease overall event, target lesion failure, which is the death, MI, and revascularization, you decrease by 31%, death by 46%, MI by 20%, stent thrombosis almost 50%, and then, of course, the revascularization by 30%, 29%. So seems to be imaging. Then should it be IVUS versus OCT? The data are kind of similar. There is a trial called OCT-IVUS, which showed no difference, and so. So what happens in the America at present? Compared to many centers do a lot of imaging. At present, America, 29% of the PCI are being done with the imaging, and 75% are done with the IVUS and 25% OCT. At Sinai, we were very low in that number, but we are catching up there. We are 26% now as of the last quarter, and 90% we are using IVUS and 10% OCT, because OCT is just here to give a dye, so we are very much concerned about that. Okay, the next one is plaque modification imaging. So imaging, but does it help in the plaque modification? What does plaque modification means? Usually, when we have blockage, we put a balloon, open the lesion, put a stent. But if you have calcific lesions, some bifurcation, occlusions, so you modify the plaque. And with plaque modification devices, we have a rotational atherectomy, orbital atherectomy, laser, and then we have IVL, which is the shock wave. So all those to modify our inelastic and calcific plaque before putting a stent. So question is, by using this modification strategy, the imaging, in these modification imaging, trial, does it help? So there was a very nice trial called Target 3C. It has not been published yet, but it has been presented. The OCT guided, angio guided, and IVUS guided. So all the patients who have calcific lesion, moderate to severe calcific lesion, and using all three technology, could be IVUS, OCT, and angiography. And they basically showed that by doing this, stent area did not make any difference, as you can see here. Malapposition, this is all means that stent which is not fully opposed, and other complications by imaging did not make any difference when you did the modification of the plaque. So this is what was the conclusion basically was, but there were some differences. And what were the differences? Basically, that once you use imaging, the late loss, that means that how much restenosis has taken place, is what significantly decreased in the OCT guided, and of course compared to angio guided, and there was slight difference, although non-significant, between OCT and angio. Then also the restenosis point of view, it's about no significant difference, and so. So basically we learned that imaging, we always teach people that once you do complex case, you do a plaque modification, you use imaging, but this trial did not favor that, except some positive benefit were there, and you see the clinical endpoints, absolutely no difference, although numerically looks like in the IVUS and OCT was lower than the angio, but not a significant difference. Then there was a trial, let's compare all these three devices: rotational atherectomy, lithotripsy, which is the shock wave, and ALCA, which is the laser, and particularly in the calcific lesions. And this is basically showed that RA versus new technique, and if you cannot do, then you use a second device. Basically, it looks like that rotational atherectomy and IVL kind of were equal, but laser, if you compare with the laser, was inferior. And then also, if you see the stent area, there are few individual points which were noted in the rotational atherectomy, IVL, and the ELCA. So it seems to be that although numerically was not different, the p-value wise, but seems to be that ELCA in overall, in the stent expansion and the minimal stent area was favored in the non-ELCA team, which is basically the rotational and the IVL. And therefore, it's basically, conclusion was that both techniques are similar, rotational atherectomy and IVL, but not the laser. Laser is inferior. Then we did the trial, which is using the rotational atherectomy for ISR. So I showed you the agent trial with a drug-coated balloon. And this trial showed basically using the rotational atherectomy versus a balloon angioplasty, there was no difference, actually rather negative in all the way. So rotational atherectomy with ISR does not work. The next one is the senior RITA trial, which is the invasive strategy for older MI patients. Remember, we learned quite a bit that patients with STEMI, they should do benefit by having a angiography and complete revascularization. But what about the old patient? The trial done in the UK, senior RITA trial, which is the patients 75 years of age, non-STEMI. If you're STEMI, yes, PCI, go for intervention. But what if you're non-STEMI? And we know that non-STEMI, there is a totally different genome phenotypes. So usually patients are more heart failure, elderly, debilitated, multiple comorbid conditions, which we know otherwise non-STEMI versus STEMI characteristics. So therefore, these guys said, you know what, let's see that in non-STEMI and old patients, should we leave it alone by medical therapy, or should we take them to the cath lab? Okay, so this basically was the trial of the 6 and 1 month and then 5-year data of the invasive treatment versus conservative treatment. And of course, conservative can always get invasive if they become unstable. And what they found, that in the invasive group, 90% patient went for angiography, majority by radial. But look at that, revascularization was done only in 50%. Why? Because those were very diffuse disease or the LV dysfunction. So whatever the reason was, they did go for cath as planned, but only half they got the revascularization because small vessels or whatever reason, there are a lot of reasons why, particularly based on the lesion, revascularization was not done by the interventionalist. And in the conservative group, about 6% went for angiogram. So this is what we had at the base. Now, with that information, what was the outcome? And you see here, death or MI at 5 years, 4.2-year follow-up, absolutely no difference. In old patients, 75, non-STEMI. Individual endpoints are right here, death, MI, revascularization, slightly favor the invasive strategy, we understand, because patients who did not have initially may require later, but that did not have any cost of the death, MI, stroke, or bleeding point of view. So seems to be that elderly patient, non-STEMI, can be managed. So nothing wrong in now. There is a robust patient, didn't have much in terms of otherwise. They went through the frailty score and all that. But some patients, of course, will benefit. But as such, we can make a point that an elderly patient with the non-STEMI, invasive strategy did not result in a significantly lower risk of cardiovascular death or non-fatal MI than a conservative strategy over a median follow-up of 4+ years. Very important. Then the Sydney 3 study. This question comes up. I know some little bit earlier also, that if you use one drug against DAPT, ticlopidine or clopidogrel post-PCI. This is a PCI patient, not the PTA. So we have 6 trials where there is a very discontinuation of the DAPT 1 to 3 months. Of these trials of the DAPT was 12, means 2 antiplatelet therapy. And then ticagrelor monotherapy in 80 to 200 patients. Twilight is the big one. Clopidogrel monotherapy in 36%. Prasugrel monotherapy is kind of not counted because we don't have much data on that. This is basically all the trials which have been done. And the Sydney 3 put it together that if after you need to give one drug and you can compare against the DAPT, that you take a ticagrelor monotherapy, no difference in primary endpoint, but there's significant decrease in bleeding. So the NACE is in favor of the single antiplatelet therapy. So with that note, we actually have started using after 1 to 3 months, and those are the guidelines now. That 1 to 3 months later, you can make it a single antiplatelet therapy and take away the aspirin. Aspirin was the culprit. So this looks good for our ticagrelor. But what about clopidogrel? So let's look at the clopidogrel, that there is an event you hear, p-value 0.13, which is that you start having some event. So it is just lower, but you cannot say what we saw in the previous slide. So therefore, and then, of course, the bleeding was lower. And therefore, basically was that seems to be that we have solid data that you want to make single antiplatelet therapy after 1 to 3 months of discontinuation of the aspirin. It should be there should be a Brilenta compared to our clopidogrel. So basically they said the systemic review meta-analysis found that ticagrelor monotherapy was non-inferior to DAPT for all-cause death, MI, or stroke, superior to major bleeding and NACE. Clopidogrel monotherapy was similarly associated with reduced bleeding, but was non-inferior to DAPT, and so. So therefore, if one drug, it should be your ticagrelor. Then there's some data on the FFR trial, the FAME trial, 3-year follow-up, some complexity in the flower MI 3 years, what it is. Remember that FAME 3 trial was patient with a 3-vessel disease without left main, FFR-guided PCI, or went for CABG. And we have 1-year data, and now we have the 3-year data, which was in 96% of cases, and basically showed that the CABG benefit sustained in terms of death, MI, and stroke, and repeat revascularization, significantly lower in the CABG group compared to the PCI group. As you can see here, 3 endpoints, p-value of 0.07, individual endpoints are here, no difference in stroke. Now, within this, they found that patients who had a lower syntax score, PCI did better. Who had higher syntax score, CABG did better. In the intermediate group, which is 23 to 32, both still CABG did slightly better, and so. So within that analysis, recently the data came of that FAME 3 trial, that what if the cutoff of the low number used to be 22, but what if you go to number 25 or 26? So more patients can benefit from the PCI, can be look into it, and then second is the functional syntax score where the FFR has been done. So what we learned basically in this is that the cutoff, which used to be 22, in terms of the PCI benefit, it may not be there, it may be probably 25. And this basically, the analysis of this paper was that rather than 22, if you go to further up, you still have a benefit of PCI, and that's what they said. Patient with multivessel disease without left main, PCI and CABG outcome remain comparable up to a syntax score value in the mid rather than low 20, not 22, 25, which allows the identification of greater proportion of patients in whom PCI may be reasonable alternative to CABG. Then the second was 3-year outcome. Of the STEMI patients, complete revascularization using with the FFR guidance, the flower MI trial, the FFR guided, angiographic guided, and basically showing at 3 years absolutely identical outcome. So FFR guided did not pose or give any advantage, and rather, actually in some places you may say a little disadvantage. This is the FFR guidance. As you can see, the red height of the red bar, recurrent ischemia. Like there is a trend towards higher recurrent ischemia hospitalization in the FFR guided. So therefore, patients with multivessel disease, in STEMI patient, FFR guidance did not do any benefit, even at 3 years. Now there are 2 trials, flower MI and frame MI. I think if you put it together, you can just say that FFR guided does not have any advantage. So if you do multivessel PCI in patient with a full revascularization in STEMI patient, you go by angiogram, more than 70% lesion, it's okay to go PCI. You do not need any additional testing to do your procedure. Then we actually, while the United States also comes with a guideline, Europeans are way ahead of us, at least 2 to 3 years ahead of us. They came up with the latest guideline of the ESC, update in management of chronic coronary syndrome, the stable angina we used to call, or stable ischemic heart disease, that has been changed to now chronic coronary syndrome versus acute coronary syndrome, ACS versus CCS. And they have actually important point that we always used to just concentrate on the MI caused by the epicardial vessel occlusion. But we also learn now there is a microvascular. How many times we patients have normal coronaries continues to have chest pain? And many of them actually come with a myocardial infarction, but epicardium is good. So that is the lot of emphasis on these guidelines as the mechanism of MI, not only just the structural, but vasospastic disease, microvasculature, and of course, the arterial remodeling, and some type 2 MIs and so. So some of the important guidelines was that there was some question already came up. The CCTA has become the class 1 indication for screening patients who have disease, and then, of course, patients who have clear-cut disease, you have high likelihood, go for direct angiogram. You don't need to go do with the many functional testings and see. Here, the patient with the invasive coronary angiography is preferred, who are very high pre-test likelihood, low threshold angina, findings suggest you a poor prognosis. Don't waste time. Go to direct angiogram. Other patients, then of course, you based on the testing, you can decide CCTA has taken a prime, I would say, place in screening these patients, as shown in this further diagram. Now, second, which I mentioned earlier, the heart team discussion in any complex case is every guidelines are suggesting that, and also the imaging, which I mentioned earlier, now has become class 1 indication. We don't have that in the United States yet. Not of Europe in our ACCHA guidelines. But based on the immense the trials and number of data, the imaging has become class 1 indication, particularly in the complex cases of the bifurcation, left main, long lesions, and total occlusions, and so. And then lastly, that very important, that choice of the revascularization modality. Look at this. It is recommended that physicians select the most appropriate revascularization modality based on patient profile, coronary anatomy, procedural factor, EF, and patient preference and outcome expectations. Because many people know, many doctors know that this patient, even if 55, left main, bad disease, 3 vessel, not going to go for surgery, don't force him. Because the patient choice is very, very important. Now, as long as interventionists say, you know what, if my complication will be much higher, I'll kill the patient on the table. It's a different story, which will not happen at Sinai. But key is, unless than that, if patient wants it, that's okay. After you have a heart team discussion, and we actually published our paper also that although those patients will have slightly higher complication compared to the guideline, but this is what is done. Almost 50% of patients go against the guideline recommendation, and which is we follow them. Another point happened that patient with the unprotected left main disease, simple cases, they become class 1 indication. This is antiplatelet therapy, which have been spoken about. And then people always ask, I need to do some exercise. What it is? Aerobic physical activity, at least 150 to 300 minutes per week of moderate intensity, or 75 to 150 minutes per week of vigorous intensity. So kind of 30 minutes, in rough, 30 minutes. If you can do 5 days or 7 days, that's good. That keeps you healthy. And of course, a lot of emphasis on your behavioral approaches, do yoga, healthy lifestyle. And I know Anu is very big on that eat the good, non-junk food, although in cath lab we have a lot of junk food, which is a different story. The other point is, as I mentioned, the drug-coated balloon, the DES is recommended over drug-coated balloon for restenosis and then arterial bypass. There is a new device. They actually went to the 2B already, called coronary sinus reducer stent, which we're doing now. Very small number, Cosira device goes to the coronary sinus, decrease some angina. We are not very happy with the results, but yes, this has been as a part of the recommendation. And another important was those ANOCA and INOCA, which is non-obstructive coronary arteries, patient angina versus ischemia. There's a lot of emphasis on that you need to do analysis, microvascular assessment, and this is where being done in our lab. Joe Sweeney has a whole dedicated program for this assessment of this. And also that we have to be more diverse in all types of patients, whether older, female, social, geographic, under-investigated groups, that medical, that all treatment should be equal. And that we all learn about this thing. Then adherence. The disease, healthcare provider, patient therapy, and healthcare system, the multiple tasks. by multiple people to really come up with the adherence of the therapy, not just start it, but adhere it. So top advance it still remains mine, the PREVENT trial. And what is PREVENT trial? It's the PREVENT PCI for vulnerable plaque. So there is a trial called combined OCT FFR. So I'll take you 1 minute because this is the whole which I'm going to show next 2 minutes is based on this concept. That you have the blockage, diabetic patients, they did the FFR of the lesion. And you have FFR less than 0.8, should get PCI. Everybody knows that, right? They do better. Now your FFR is more than 0.8. But we know that more than 0.8, the event rate is not 0. There's still some event rate. But what if we can divide in those, do the OCT in those cases, and you find out that there is a TICFA, which is the thin cap fibroatheroma, or those do not have TICFA. TICFA negative and TICFA positive. So guess here, this is the PCI which needed. If you didn't, you have TICFA positive, that red, did not do PCI. Guess what happened? Event rate at 6 years, 24, almost twice than what you did the PCI for. So you say that maybe this group is vulnerable. This is a trouble. And this we, as an interventionist, have been thinking for years. That what if we can make a complication of PCI very low, maybe we can improve the life of these patients. And that is what exactly this trial was. Done in Korea, that preventive PCI versus optimal medical therapy alone for treatment of vulnerable atherosclerotic plaque, PREVENT, multi-center, open-label randomized trial. This started with Korea. There is some other centers, the Japan, New Zealand were, and they defined the vulnerable plaque by 4 characteristics: MLA less than 4, plaque burden more than 70, TICFA by OCT, which we saw, or by radiofrequency IVUS, or lipid-rich plaque on NEARS. These are the definitions. And so, and the basically, based on those who have a positive, with the vulnerable plaque, 1 or more feature, could have 1, could have 4. They were randomized to, it started with the BVS, later on, with the bioabsorbable stent, but that disappeared later. So DES versus medical therapy, and follow these patients up to 2 to 7 years. And basically, very important, everybody has a great medical treatment of the risk factor reduction. As you can see, the LDL, BMI, systolic blood pressure, smoker, A1C, all were very well controlled. Angina status, as you can see here, the slightly kind of not much different between 2 groups, but seems to be always in the PCI group, that lower degree of the class 1 angina. But this is where the crux is. The preventive PCI versus optimal medical therapy, primary endpoint decreased almost by 3 points. Death decreased by 2 points. P-value just made it 0.35 to 106. Remember, we do so many things to decrease the mortality by 1%. Then any MI, any revascularization, hospitalization for unstable angina, composite endpoint, all in favor of preventive PCI. So a lot of people say, you know what, I'm making too much out of it. They did unnecessary stenting, because in this group, 790 stents were placed, and in this one, OMT, at a follow-up, 41 stents were placed in another 2 years. So because those who start having symptoms. So we are comparing here about 780 stents versus 41 stents, but I say understand. But did stenting cause any harm? And the answer in this slide is no. So first thing we want to do is no harm. We did that. Second, did the patient benefit? Because there are some data, anecdotal data, small non-randomized data, that those cases, if you don't fix it, they have high event rate. And it was shown here. And this was only, and then other endpoints, ischemia-driven TVR, look at the significant difference, and then no difference in stent thrombosis, no difference in bleeding or stroke. So overall, it seems to be favored the preventive PCI, and it was only possible because the PCI complication was less than 1%, 0.4. If this would have been 3 or 4%, then of course negative. So we perfected the PCI before testing this concept that yes, preventive, the PCI in these cases may help, and you see the individual endpoints on the right side. And so basically, this was the conclusion that given the PREVENT is the first large trial to show the potential effect of the focal treatment for vulnerable plaque, these findings support consideration to expand indication for PCI to include non-flow limiting high-risk vulnerable plaque. This is, to me, conclusion which Lancet is a very high-impact journal. They let this conclusion come. I think it was a little very aggressive conclusion because this is one trial only. There are 3 trials in the making. The one is the combined intervene trial based on the OCT, and they have the whole criteria. Then follow up these patients. In the second is the interclima trial, this patient in acute coronary syndrome. And the lastly, patient with the MI, with a multivessel, the criteria are different, but all focusing on that you do not need to do PCI in one group based on the available data, but you have some measure of their vulnerability. Is PCI going to improve their outcome? Will take us another 2 years. But with these numbers of another 3,000-4,000 patients, I think we will have some answer, and then maybe the conclusion of the Lancet conclusion of the PREVENT trial may be correct. So let me sum it up now, which I say always the central illustration, what I have spoken last 30 minutes, 35 minutes. 1, ECMO in cardiogenic shock, ROTA in instant restenosis, drug-coated balloon large native vessel. No good, should not be done. Then FFR-guided PCI in multivessel STEMI, invasive strategy in old non-STEMI, and laser in calcific lesion, 1 thumb down. Cabbage over FFR-guided PCI, increased mortality with spontaneous or procedural MI. I think a lot of understanding and better. Then Impala in cardiogenic shock, IVL and or rotational atherectomy in calcific lesions, ticagrelor versus clopidogrel alone over DAPT, and 224 European Society guideline for CCD. I would say 2 thumbs up. Then DCB in ISR. Imaging, OCT or IVUS in complex lesion and plaque modification guided PCI. 3 thumbs up. And I would say that I was earlier used to make 4 thumbs, but I made it 3.5. Little small, because a lot of criticism. I said, okay, I had never given anybody 4 thumbs up in my 25 years, so I am not giving 4, I'm making 3.5. With that, we PREVENT trial to make us the better interventionist and improve patient survival. And thank you very much.